Good evening and welcome everyone. I'm Dr. Amit Bose. I'm Head of Medical Marketing Initiatives at MCure Pharmaceuticals. Our division is called IVA and we are a dedicated IVF division. We are on a mission to nurture and support 28 days. Programming 28 is a scientific theme for the year and is based on the concept of managing an ovarian cycle with different gonadotropins, analogs, and hormones. Materna is a prime brand and is an epitome of quality and success. Today, we are very thankful and proud enough to host this another episode, that's the third episode, interview with international icons of IVF. From our art, we thank you, Dr. Rajan Vaidya sir, to give us this opportunity to host this event and the complete series. We are also very thankful to Dr. Meenakshi ma'am to accept our invitation to be as a co-host. We also thanks Dr. Shailaja Nair ma'am to help us to take this forward. And a very hearty thanks to Professor Nicholas sir to accept our invitation to be a faculty for today. We also have today with us Mr. Nikhil Mehra. He is our national head for our division and would be speaking 2 words. Nikhil sir, may I request you to take over?
Thank you, Dr. Amit. Thank you very much. So a very warm Sunday evening to everyone out over here in India and a warm good afternoon to everyone in London. On behalf of MCure, I would like to take this opportunity to thank our host, Dr. Rajan Vaidya, Dr. Meenakshi Chaudhary ma'am from London, Dr. Shailaja ma'am from London, and Professor Nicholas Macklon from London, and to all the delegates present out over here. I'll not take much time just to give you a glimpse about MCure. So MCure is the most prestigious organization in pharmaceuticals in India. We are the organization which is available in 70 countries worldwide. And when we talk about India, we are among the top 10 pharmaceutical company in India and #1 in the field of gynecologicals. Moreover, we are the most preferred partner in the field of infertility. I just want to share, you must have seen our Prime Minister, Honorable Narendra Modi ji has recently visited USA. So from there, he announced that in India, an Indian organization is coming with mRNA technology vaccine in COVID. So that is something which is coming up by MCure. So great to share all these insights about MCure, and over to you, Dr. Amit.
Thank you, Nikhil sir. I'll take another minute to introduce our co-host and our supporting faculty, Dr. Shailaja Nair. So we have Dr. Rajan Vaidya sir. He is an honorary consultant, Norozji Wadia IVF Center, Parel, Mumbai. We have our co-host, Dr. Meenakshi Chaudhary ma'am with us. From United Kingdom. She is a senior consultant in reproductive medicine, Newcastle Fertility Center, Department of Reproductive Medicine, Newcastle upon Tiny TNS Trust Hospital, United Kingdom. We also have with us Dr. Shailaja Nair ma'am. She has been working in fertility in UK since 1998, Deputy Medical Director of the London Women's Clinic, Harley Street, London since 2004. Now a Deputy Medical Director at the London Egg Bank, which is integral to the London Women's Clinic. May I now hand over the session to our host, Dr. Rajan Vaidya sir. Sir, all over to you.
Thank you very much, Dr. Amit, for the kind introduction. Good evening to our viewers from India. Good afternoon to our viewers from UK and Europe, and good morning to our viewers from United States and other parts of the world. Am I audible? Can I be heard?
Yes.
Yeah. It gives me an immense pleasure to introduce our speaker, Professor Dr. Nicholas Macklon, a very renowned international speaker in the field of assisted reproductive technology treatments. Presently, he is a medical director at the London Women's Clinic, London, United Kingdom. He has been a past chairman of the European Society of Human Reproduction and Embryology, what we call as ESHRE, and also was heading the special interest group in the reproductive medicine at ESHRE. He had been a past professor of obstetrics and gynecology at the University of London, United Kingdom, University of Southampton, London, United Kingdom, a visiting professor at the Zealand University Hospital, Copenhagen, Denmark, and a visiting consultant at Adelaide University Hospital. Professor Macklon's research interests have been primarily focused on ovarian stimulation, endometrial receptivity, and periconception. He has published more than 200 papers in the renowned international journals. His research group contributions towards understanding the regulation of human reproduction have been recognized with number of awards in various countries. Professor Nick's interest in the periconceptual determinants of reproductive medicine or reproductive outcomes has led him to editing some of the very reputed textbooks like Textbook of Periconceptual Medicine and IVF in Medically Complicated Patients. Professor Nick brings a considerable editorial experience to his new role as editor-in-chief of the very reputed Journal of Reproductive Biomedicine Online. He had also been an associate editor of the Journal of Human Reproduction Updates, and a member of the editorial team for the Fertility Sterility Journal. He has also been a guide to several PhD students. And dear all, that was a very, very brief summary of his huge bio sketch. I'm sure that since everyone is very eager to listen to Professor Nick Macklon, I now request Professor Nick Macklon to please commence his talk, as everyone is very keen to listen to you. Over to Professor Nick Macklon.
Thank you very much, Dr. Rajan, and to all my dear colleagues for inviting me to speak to you today. I'm just going to be sharing my screen, and I just want to make sure also that my video is working, so hopefully this will work for you. So hopefully you can now see something apart from just me. Is that true?
True.
I hope so.
Yes.
Good. Well, look, I'm grateful for the chance to speak to so many colleagues on a topic which I think we all struggle with, don't we, every day? This issue of recurrent implantation failure. And I've been asked to focus on evidence-based management strategies, and that's what we're all looking for as we look to help our patients with this difficult situation. I'm speaking to you today from here in Harley Street, that building on the right that you can see. I'm in there at the moment in my little office, which is our sort of main clinic alongside the Bridge Centre, where Dr. Nair is in charge of the London Egg Bank and a sort of very senior consultant with us in London Women's Clinic, has been for many years. We have clinics throughout the UK, as you can see there, and also quite uniquely, we have this very strong association with the Egg Bank and the Sperm Bank. Historically, what's quite nice is to know that it was actually none other than Robert Edwards who founded this clinic way back, and it was his PhD student Kamal Ahuja who then took over and is still the managing director and scientific director today. But let's get to the topic, that of recurrent implantation failure. And we always need to start, don't we, by defining it. And this is still an ongoing discussion, as I'm sure you will agree. In the old days, before we used to, in the days when we used to transfer lots of embryos, we would tend to get worried about things when 10 embryos had been transferred without success. But these days, it will take a long time to transfer 10 embryos. And therefore, we've needed to modify the definition. And this is one that was published in 2014, which I think does its best to really pin down what we should be referring to as recurrent implantation failure. It is quite complex. It says it's the absence of attachment of the embryo after 2 consecutive cycles of IVF, ICSI or frozen embryo replacement cycles, where the cumulative number of transferred embryos was no less than 4 for day 2 embryos and no less than 2 for day 5 embryos, with all embryos being of good quality and of appropriate developmental stage. It's very complex. And I think that while I think you need something like this perhaps for research purposes, let's be honest and say that in the clinical situation, the doctors, we encounter RIF not as a medical condition that can be defined in this way with a single cause, and I'll come back to talk about this later, but it's basically an experience of disappointment, an experience of repeated IVF failure sufficient to call for additional action by the patient and by us as well. So it'll be that time in the treatment where we think, gosh, what else can we be doing here? And to be honest, I don't think you can pin that down in the way that people have tried to before, because it's hugely dependent on context, the age of the patient, the financial context of their work, and what tests they've already had. So let's acknowledge that what recurrent implantation failure is a term we use when we have a patient who is struggling and we can't really quite work out why. That's really what it is. Now, when we think about why embryos don't implant, we tend to think it's just the embryo. And I think that has been the model of our thought for the last 20 to 30 years. And there has been much justification in that, because even people like me who are particularly interested in the endometrium will acknowledge that the embryo is the key determinant of success. That's why we see results falling in older women, of course. And more recently, I think in the debate about recurrent implantation failure, there's been a particular focus on this because of the use of pre-implantation genetic testing. And many of you will have seen this paper published in Fertile Sterile, but also referred to at a number of conferences over the last year, where a Richard Scott's group looked to see what happened if you had 3 successive transfers of euploid embryos. How many people got pregnant? So they had this large cohort of 4,430 patients who underwent an embryo transfer with a euploid embryo. Around about 75% of them got pregnant, 70% rather, and those that didn't then proceeded to a second one, and then those that didn't proceeded to a third. And they reported that, as you can see in the graph below, if you did that, then 95% of them got a pregnancy. And their conclusion was that recurrent implantation failure does not exist, because as long as they get enough euploid embryos, basically everyone will get pregnant. And that is a very powerful and compelling argument. But there are some issues with it. The first thing is that if it is just about euploidy, then everyone should get pregnant the first time. And the second one is that even after 3, there's still not everyone is pregnant. But still, it suggests that we could probably end the lecture here and say, well, the way to manage recurrent implantation failure is to give everyone a euploid embryo. But the real world's not like that. Most of our patients will either not have PGTA testing, or they will and not have access to 3 euploid embryos, or they may have mosaics, which we're increasingly transferring now. So I do think we still need to consider the endometrium in this problem. It may well be that when the embryo is perfect, as in their study, the endometrium is not really a significant factor. The top quality embryo will fight its way through anything to implant, and I think there's probably some truth in that. But most people presenting with recurrent failure do not have access to endless perfect embryos. And in those circumstances, when the embryo isn't perfect, there is increasing evidence from the work from my group and from others that the endometrium does become a determining factor. And that if it's not operating normally, it may actually make the difference between a successful implantation or not. And I think that that is the situation in the vast majority of our patients, sadly. And the other point is that it assumes that the endometrium is just a passive, non-engaged matrix into which the embryo invades. And it's clearly not the case. We are now learning much more about the very active role that the endometrium has in implantation. And I don't have time today to talk a lot about our work in this or others, but I am going to show you a video some of you may have seen, which I still enjoy watching. It's from one of my PhD students in Utrecht, Charlotte Weimar, who placed a day 5 embryo onto a dish between some cells. She had some decidualized stromal cells from a biopsy, put a little scratch through it, and that's that gap or that river you can see between the cells, and placed an embryo on it to watch what would happen. And we would have assumed that the embryo would fight its way through this passive inert cells below it, or spread out on it and invade, because those are the pictures we've seen. But she watched it for 18 hours and she saw something very different. The embryo just sort of sat around, but the cells clearly detected its presence and reached out to engage with it and to start moving around and actually encapsulate the embryo. And I think while this is in vitro, and therefore one has to be careful of how you extrapolate this to the in vivo situation, it gives us a very compelling example of the fact that the endometrium is listening out for the presence of an embryo, engaging with it, and then basically smelling it to see if it's a good one, and whether or not to invade, whether or not to allow it to implant. And this concept of invasion, which sounds a bit one-sided, is probably not true, that the drawing of the embryo into the endometrium is probably as much by the endometrium as it is by the embryo. So I hope that we can start from that premise, therefore, that the endometrium is important. So let's think about then, clinically, how we're currently managing recurrent implantation failure. And I think this is probably what most of us are doing. When we see a patient in this frustrating situation. We will review their previous cycles for clues. Was there anything there that didn't go right that would point to a problem? And that seems a very appropriate medical thing to do. And then maybe to try changing things, even when there isn't a clear problem, to try adding things. And let's be honest, cross our fingers and hope. And if it goes well, we'll be very pleased to take any credit that's going. And that's what we all do every day that we practice. So what do we try and change? Well, we could maybe try the agonist protocol instead of the antagonist. No obvious reason for doing that other than we try and change something. More complex stimulation protocol. We try a frozen rather than a fresh embryo transfer. We try ICSI rather than IVF. We try IVF rather than ICSI. We try 2 embryos instead of 1, or 1 instead of 2. We might think there's a place for PGTA, or indeed assisted hatching, and this list could go on and on. We might add things, endometrial co-culture, a scratch. There's even some studies that have suggested putting in a copper intrauterine device for a few months is quite good, just to reset the endometrium. We might try and stimulate growth factors, or modulate the immune response, or improve blood flow with aspirin or Viagra. All very natural things to do as we desperately try and help our patients stay confident, stay with us, and hopefully get pregnant. But this topic is a roundabout evidence-based practice. So I want to spend the next few minutes just looking at the evidence for some of the interventions that perhaps are more established and some of the newer ones that our patients are asking about. So I think perhaps one of the most common things that's used in practice to try and help implantation, particularly in women where they're struggling, has been to give glucocorticoids around the time of implantation. This has been something that's been going on for a long time, and some years ago now, one of my PhD students in Utrecht, Stephen Kay in Warwick, and myself carried out a Cochrane review, which we published actually originally a few years early. This was the first review in 2012, to look at the evidence that giving glucocorticoids might improve implantation. Now, these things need to stay up to date, and what I'm very happy to do today is to share with you the current status of this review, and I would very like to point out the important input that a colleague of ours from Vellore in India, Mohan Kamath, may be watching this evening. If you are, thank you, Mohan. Terrific work on this, because we've now completed a new latest update, and you are the first people to see this. It's under review. And that means it comes with a health warning, because this still needs to be reviewed by peer review, but I hope it will still make the point of where we are with this. So what Caroline and Mohan were able to do were to identify 16 RCTs, including 2,232 couples, and to look at the chance of live birth rate. And here there would seem to be an uncertain difference in live birth rates if you use glucocorticoids, and there are several different regimens which they include, and you'll need to wait for the publication to see the different regimens that were assessed. But essentially the bottom line was that if the chance of live birth following no glucocorticoids or plus placebo is considered to be about 9%, the chance following use of glucocorticoids would be between 6 and 21%. What does it say? It says we don't know whether it has any real benefit. It may be beneficial, but it may be detrimental. And the same essentially applies for pregnancy rates with 13 RCTs, odds ratio of 1.12 with confidence intervals crossing unity. So again, we can't be certain it's having an effect, and also with miscarriage rates. So the conclusion we must draw at the present time, unless the review changes under a peer review, and of course it always could, is that at this moment there's insufficient evidence to support the use of glucocorticoids in unselected patients. And I use that word purposely because these patients who were included in these studies, they came from a range of different medical contexts, but none of them had any diagnostics of the uterus to determine whether or not glucocorticoids might have any rational basis other than a general feeling that immunosuppression must be a good thing in everyone. And I'll be talking about that later. So what about other intrauterine therapies? And these are beginning to creep into practice now, and I just want to spend a few minutes talking about them. They are sometimes quite expensive. Many of them are controversial, but the stories behind all of them are quite compelling. The rationale seems to be very attractive. So let's just spend a few minutes looking at what data is out there to guide whether or not we should be using them. And I want to start by talking about PBMCs, intrauterine injection of peripheral blood mononuclear cells. Now, there's a very broad definition of what we're talking about. Basically, any blood cell with a round nucleus, such as B and T lymphocytes, monocytes, or macrophages. And all of these cells are implicated in the process of implantation. So why don't let's add some? I mean, basically, that's what it comes down to. A rather crude rationale, but still an attractive one. And partly because PBMCs, these cells in vivo, in the uterus, are implicated in the interplay between the embryo and the implantation site through a range of mechanisms which I've touched on there. And initial studies, as is often the case with these things, looked very promising, particularly in women who had RIF, and people got good results. But they weren't controlled studies, they were just case reports initially, which are often positive, otherwise they wouldn't get published, or indeed small cohort studies. Now, we do have now access to a systematic review and meta-analysis of the published studies. And many of you will be very familiar with how one looks at these critically, and you look, of course, what were the size of the studies, what type of study was done, before we go anywhere near the forest plot on the right-hand side, which tends to draw our eyes so quickly. So let's have a look at this. You can see a couple of studies, absolutely tiny. One very dominant study by Lee in 2017, but the events were rather unbalanced between the two, as was the study sizes. So amongst that group, there are just two that are randomized controlled trials. They're very heterogeneous in the way in which these were used, and the patient were used in the studies were small. So the conclusion was that even though the forest plot at first look looks quite interesting, really the quality of the evidence doesn't allow us to make any conclusions. So we're still unclear about this. What about increasingly popular intrauterine platelet-rich plasma? It's derived from fresh whole blood, centrifuged to remove the red blood cells, and what you have essentially is a suspension of platelets. And we know that these release some of these key growth factors that are involved in implantation. So why not put them into the uterus and see if that helps? They also have antimicrobial and anti-inflammatory properties. So it does look tempting to put these into the uterus and see what we might see. So we do have a recent meta-analysis here too. And again, if you look at the forest plot, initially it says, gosh, this looks very convincing, let's go out and give it to everyone. But again, the study sizes are very small. And only 2 of these studies are randomized controls looking at recurrent implantation failure. None of them had a placebo arm, so there's always that risk of a placebo effect or confounder. No diagnostics were done beforehand to assess whether there was a shortage of EGF and VEGF that could be compensated, and no live birth outcomes reported. So again, we have to be cautious about interpreting these data. What about HCG? Again, a very compelling story. It's a key embryonic signal. May promote peritrophic blastic immune tolerance, facilitates invasion, regulates proteins involved in apposition and adhesion. And some of you will be familiar with some of the papers I've listed there, which showed us that the HCG probably secreted by the embryo probably does have a role in implantation. And added to that is the study by Licht, which I think is quite influential in this field, showing that when you inject HCG into the uterus and then look at what's produced by the endometrium, it does seem to influence them. So a compelling story here. So should we be doing this? Should we be putting in HCG into the uterus? What dose and when should we be doing it? And again, we can go to the Cochrane Library for some guidance on this, published in 2018. And another forest plot, I'm afraid, but just let me guide you through the main things here. Essentially, there's been quite a lot of studies, not all of them randomized controlled trials, of course, which are often very difficult to do in this kind of setting, as you can imagine. But if I was to draw some conclusions, it would again be about the quality of the studies being poor, the heterogeneous, and the studies on the whole being quite small or unbalanced. But there does seem to be a signal here that there may be a group of patients who might benefit from quite high dose HCG around about day 3, day 2 of after the embryos, after the eggs have been fertilized, presumably because that would give time for it to have some impact on the endometrium. We don't see it if we give it the blastocyst stage, at least according to this analysis. And the conclusion of the writers of this Cochrane have said that the pregnancy outcome of cleavage stage embryo transfers using an intrauterine HCG dose of 500 units or greater is promising, But small size, variable quality of the trials, and the fact that the positive finding was from a subgroup analysis means that the current evidence does not support its use in assisted reproduction cycles. So that's another one we are told to scrap from the book. The last one, intrauterine granulocyte colony stimulating factor, has been particularly popular when we're dealing with this difficult issue of thin endometrium. Very mixed data on that, but again, quite an interesting, compelling rationale. Stimulates the bone marrow to produce granulocytes and stem cells, releases them into the bloodstream. They come along and they regulate endometrial gene expression, angiogenesis, cell migration, and apoptosis. So let's look at a Cochrane review on this too. Well, there did seem to be some evidence that in this group there may be a possible benefit on clinical pregnancy rate, but we didn't see it on ongoing pregnancy rate. And this raises, I think, one other issue we just need to be careful is when we're forcing embryos to implant by adding these mixtures of goodies into the uterus. They may help implantation and they may help a positive pregnancy test. But there is also the possibility that what they're doing is overcoming the natural selection mechanisms that we're beginning to identify in the uterus and simply turning a negative pregnancy test into a miscarriage, because miscarriage rates were interestingly here not reported. And when you look at ongoing pregnancy rate, there was no impact. And this is a worry that I think we should have, that by using, there probably are techniques by which we can force an embryo to initiate implantation and produce sufficient HCG to produce a positive pregnancy test, and we all feel great. But are we really helping the patient? And I believe we've got to be a little bit more critical about that. So let's go to something that's perhaps a little bit more simple, the endometrial scratch. And goodness me, it's been impossible to go to a conference in the last year without this being on the list of topics. It raises a lot of emotion, and there are protagonists and very active people against it. And there is a growing literature on this topic, but I think the most influential group on this has been from Cindy Farker and Sarah Lenson, and they've carried out, I think, a beautiful study, randomized trial of endometrial scratching before IVF, published quite rightly in the New England, which I think we have to agree really was the definitive study that showed that we probably should not be offering this to everyone as a routine. And I would certainly share that conclusion. This is the study design, Papel biopsy between day 3 of the cycle preceding and day 3 of the other one, of the next cycle. Large study, live birth rates exactly the same in both groups, and no difference in any others. So in a unselected group of patients where we know nothing about their endometrium, there is clearly no benefit in giving the endometrial scratch. And when this kind of study is published, it doesn't reflect very well on us, because it suggests that the reason why we're doing these things are for bad reasons, that we are simply pushing women to buy needless extra treatments. And it is something which there's no doubt that this is going on. But I don't believe that this is the prime driver for doctors using these by any means at all. I think what we are trying to do is to find in good faith and try techniques that might help our patients who are demanding these. But we do need to be cautious because our patients are very open to exploitation. And it is for this reason, I think, that the HFEA was right in trying to produce some patient-facing information that could help support patients as they consider these add-ons, as they've been called. And you can see that in the HFEA setup, when it was originally published, you could only get a green light for a treatment if there were randomized controlled trials showing it was effective and safe. And you will see that not a single one has been subjected to this or been shown to do this. And I think if one was being particularly cynical, one could ask the same question about IVF, because if you actually look at the randomized controlled trials of IVF versus waiting, I think the studies, that would not get a green light, but yet it has made it into practice because we see it working. That has led to quite a bit of discussion, including from my own group, and some of you might have seen our editorial in RBMO a couple of years ago on this, which was not supporting add-ons, even though some people have said that's what we were doing. We weren't doing that. We were just saying, look, is it right to be basing the use of these things purely on randomized controlled trials, because clinicians are probably not going to be able to access these for many years, and can we find other sources of data that can support? That's a topic for another day. But the key message here is that I think we are in a problem. We're in a problem because we have patients with RIF who demand help, we want to help, and we're being told there's no evidence-based management to help them. So what do we do? Well, we're stuck, aren't we? Why are we stuck? Well, I think there's a few reasons for this. The first thing has been that some of the studies that have been done looking at interventions have made, in my view, have been based on the wrong premise. That RIF, recurrent implantation failure, is something that probably has a single cause, and if we just find that cause on everyone, then a treatment will work. And if it doesn't work on everyone, it doesn't work on anyone. And I think that's wrong. RIF is not, as I've said, a medical diagnosis amenable to a single treatment strategy. It's a term that's given to a clinical presentation that has a range of causes, and the same applies, frankly, to recurrent miscarriage, as it does to abdominal pain. You know, we wouldn't give everyone with abdominal pain an appendicectomy. You know, we would probably do a diagnosis first. We are testing interventions in the wrong way because of that. Because we're running a trial with women with recurrent implantation failure, and we're giving them steroids, and the steroids might be helping half, hindering the other half. It comes out as no effect, and we decide to reject the intervention because it doesn't seem to work empirically, risking us, keeping us stuck in this one-size-fits-all clinical paradigm. So I think this discussion is now beginning to be had. I think we've moved beyond the, you're wrong, I'm wrong attitude. I think we've all recognizing this is a difficult problem and one that is not going to be solved simply. And therefore, I think it does need a new conversation about recurrent implantation failure, and you and I need to be having a different conversation with our patients about it, rather than perhaps the way we've been doing it. And there are a number of things I think that we can bring into that conversation with patients. The first, that implantation failure is probably the default of human reproduction, and it's there for a good reason. And that is that the majority of the embryos that we make are not viable, either from chromosomal abnormalities or other abnormalities. And so implantation failure is nature's way of protecting the mother from investing in a non-viable pregnancy. And if you look at, this is again Caroline's work when she was working with me in Utrecht, you can see that if you look at what happens with IVF pregnancies, the vast majority of the losses happen before the woman would have missed a period or have in IVF a pregnancy test. And this isn't just in IVF. If you look at spontaneous conceptions, there is evidence that the majority of losses happen in this very early post-implantation phase. The woman gets a period on time. She has no inkling that she's been pregnant, or maybe sometimes she's felt a little bit pregnant and then got a period. But what's happened is nature's kicked in and made sure that only those embryos that have a fighting chance to reach a live birth healthily will be able to stick around long enough to produce a clinical pregnancy. So implantation failure is actually a good thing in the vast majority of cases, and not a bad thing, and has a role to play. And it's important our patients understand that. I suppose one of the key points I've already alluded to, which I want to emphasize now, is that interventions aren't working because we're using them wrongly. The glucocorticoid story, for instance, is possibly helpful in some women where there is a need for immunosuppression. But there's probably some women where the problem is not there's too much immune activity, but there's not enough. And therefore, giving them glucocorticoids is going to do more harm than good. And I think this is beautifully articulated in a paper from Rob Norman and Sarah Robertson a few years ago in that group, who basically outlined in a very elegant, compelling way why we shouldn't just be dishing out steroids to everyone. That controlled inflammation is actually essential for implantation. You actually need some. And therefore, suppression may influence it negatively. And glucocorticoids might be harmful or beneficial or have no effect. And what I would say is that if we want to use these, and I think there might be a place, I don't think we should write these or frankly any of the interventions that we've seen today so far off completely, because we haven't analyzed them in the right way. We haven't identified the patients who have an abnormality, in this case, immunoactivation, and then randomized them to the intervention. This is something we're only beginning to do now. So we need to diagnose the cause if we are going to treat the symptom. So there's a range of diagnosable endometrial dysfunctions, and these should be diagnosed where possible. And it's easy for me to say, but where are the tests? And they're still coming. But this is the direction we need to go. By diagnosing the endometrium, we can move to targeted individual treatment approaches and test targeted rather than blind interventions. And I think this is the change in attitude we need to have. So how are we going to do that? So let us now take a few minutes to ask, I suppose, what's a very obvious and silly question in many ways. Why might implantation fail? Can we ask that question in a way that can help guide us how we answer the question? Well, I think, bear with me, but I would suggest to you it's actually fairly straightforward. There are three reasons why an implantation will fail. One is the embryos failed to thrive in utero, didn't like the intrauterine environment, or it's just not viable at all. It's failed to thrive and hasn't even initiated implantation. And this is happening day in, day out, outside of the clinic, and patients are blissfully unaware that there's an embryo that's been lost. They just get their period on time. The other one is that the embryo has thrived, but failed to initiate implantation for the similar reasons, or that the embryo has initiated, but not completed implantation. And there may be a range of reasons we might then put forward to say, well, why might that not work? So let's start with embryo that's failing to thrive in utero. Well, we could hypothesize a few interesting areas we might want to look at and develop tests for. Is the endometrial cavity environment hostile to it? We know how crucial it is that incubator settings in a lab are right. Is the uterine incubator setting right? Are endometrial secretions nurturing rather than damaging the embryo? Is there evidence of infection, endometritis? Is the microbiome optimal? Are the contents of endometrial secretions optimal? And is the pH and oxygen right? All of these are potentially measurable and diagnosable. The second one is the embryos thrived but failed to initiate implantation. We could ask the question, well, is there an inherent receptivity problem here? Is it just something wrong with the endometrium, or is it simply just a synchrony issue? That the endometrium has been receptive or will be receptive, but not quite at the right time. And the third one is the embryo is initiated but not completed implantation. And this may suggest that it's been up against it in terms of the immune environment, or this putative biosensor function of the endometrium that Jan Brozens and I have proposed over the last few years may disrupt it in some women, by which they're being too selective of the embryos, and therefore not permitting embryos that could enter the uterus and survive and make it and correct to get there, so they're not getting a positive pregnancy test. Now, all of these would need, in my view, to have a test developed to see whether they're, and this is just a short list. I'm sure all of you could think of other potential reasons why an embryo doesn't implant, alongside the embryo factor, which I'm assuming we're accepting is there. So this takes us then to the need to develop what I've called an endometrial diagnostic toolbox. Not a single test, whether that be ERA or whatever one you prefer, that says, let's do that, and if it's good, that's fine, and if it's not, it's bad. It doesn't take much to realize that any test is only going to assess one element of endometrial function, and therefore on its own is going to be quite limited in its value. So what we need to start thinking about is characterizing the endometrium or fingerprinting it across a whole range of its functions. And I've just put some up here, but you know, there could be, if you ask me in 5 years' time, there'll be another 20 that we've discovered there. It's a very complex organ, and there's much more to it than just being receptive or non-receptive. That is an overall word which I think, to be honest, has not been helpful to us. So what I've put up here are some of the things that we would look at in our setting in our implantation clinic here in London, which is based on one which I set up in the University of Copenhagen, and which we did a couple of PhD projects on over the last few years. Let me just say something a little bit about the implantation clinic and how it works. The first thing is to say that it is not evidence-based, in the sense that I don't have data from randomized controlled trials showing that if you refer a patient there, they get a better outcome. But I do believe that it's a step in the right direction over and above just trying something blindly, intralipid or whatever one believes in. And on the whole, the way it's been introduced both in Copenhagen and here, on the whole, it's something that I think our colleague doctors find helpful. If they have a patient who is having these difficulties, being able to send the patient to another colleague or another setting To have a special test is something that the patients really appreciate the doctor for having done. And I think the doctor likes quite having some help from another colleague, but they get the patient referred back. So they stay the treating physician. And what will happen is that that patient will be sent and undergo a mock cycle and a number of tests. So we will put them through a mock frozen embryo transfer cycle with HRT, and then we can do a whole range of tests on them. And I'm not saying we do all these, or we'll keep doing them, but this is the sort of thing that you might want to look at in your clinic. You could look at synchrony testing, take a biopsy, and use good old noise criteria to use histology to see whether or not after 5 days of progesterone it looks what it's supposed to look like after 5 days of progesterone. And the noise criteria are 70 years old now, and not as objective as some of the more modern tests, but essentially it's the same principle. And in our own work, we've seen some correlation between the noise and molecular markers. So it's not without value. We just need to be careful about apportioning it too much importance. The modern technique of doing this is with the ERA test, which looks at gene expression and allocates pre-receptive or post-receptive status to that biopsy. Immune cell profiling. If we want to give glucocorticoids or heparin, which is also given for its immune suppressive modulatory properties, or intralipid, then perhaps we should be having a look, not in the blood, because the NK cells there have a completely different function, but in the uterus, where we know that NK cells have a crucial role in decidualization, the endometrial biosensor, and there's not time to go into that today, but some beautiful work from Jan Brozens coming out, teaching us about the role of NK cells in keeping the uterus selective in this way. Angiogenesis, immune modulation, and placentation. The trouble, one of the troubles with NK cells, apart from their name, which of course invites us to destroy them immediately, is the fact that counting them is very difficult. They're often clumped, it's difficult to automate, and there's a huge amount of inter-observer variation in counting them. So we need to look at their function. What are they producing? And this is something that we've been looking at, maybe looking at ratios, a paper we published in ARGI last year. So Nathalie Ledet in Paris has done a lot of work on this, and her approach is not to measure NK cells, but to measure the important factors that they produce. Chronic endometritis, increasingly accepted as something that is a cause of recurrent implantation failure, diagnosable and treatable. So why don't we do that in this patient group? Different ways of diagnosing it. You can either use histology, immunohistology, or you can do hysteroscopy. There are well-described criteria for diagnosing it. It is quite prevalent in women with RIF, something we should be looking at, and treatment with antibiotics does seem to help. So one of the questions that one of my PhDs in Copenhagen asked, Malene Witt-Saxdorf, published this paper in 2020. What she did was we ran an implantation clinic in Copenhagen, and we invited doctors from around that part of Denmark to send their difficult patients. And we had a control group, and we just asked the question, if we look at these tests, are they different in women with RIF compared with controls? A very simple question. Those of you who've tried to do this sort of study will know how hard Malene had to work to get this data I'm showing you today. So 86 women with RIF and 37 controls were invited to take part in endometrial profiling. And we simply asked the question, is there any difference? Are we seeing some things more common in RIF patients? And yes, we did. We found that amongst RIF patients, vitamin D deficiency was a little bit more common. It was more common to have a slightly lower progesterone after 5 days of progesterone. There was a marked increase in the prevalence of chronic endometritis. Interestingly, ERA displacement was not significantly different between the two groups, and neither was the microbiome in this particular study. Now, what that doesn't mean is that there's no point in measuring them, because there may be a group who still have this as an issue. You need to take your own view on that. And so the way it works then, having felt, gosh, there could be some value in this for the reasons I've told you, women with RIF, despite good embryo quality, are referred. We standardize the regimen with HRT, and we include a number of tests. And I would say, you know, what you need to do is look at what's available to you and what you think might have some biological rationale. In Copenhagen, we used our own pathology service to assess the endometrium, endometritis, using noise criteria, but we also had access to ERA. But you could do some of these things in-house. You can maybe send some of the tests away to some of the more commercial labs. But on the basis of that, what we're trying to do here is produce a plan that's got some basis in rationale, rather than just saying, well, have you tried this yet? And that's what we just got to move away from, because I think we're harming as many patients as we help. And this is the sort of intervention might propose. If there's low progesterone absorption levels, in other words, it looks as if this patient doesn't seem to be getting much out of vaginal progesterone, we might add in intramuscular or subcutaneous. If the ERA test is suboptimal, we might change the number of days of progesterone before we do the frozen embryo transfer. If there's evidence of increased immune activation, however you measure that, that might be a group that could benefit from suppression. On the other hand, they might actually be reduced immune activation, and there may be a role for stimulating that with a scratch. Again, we need to be straight with patients that we need proper trials, which we're still needing, to find out whether these will be truly beneficial. But I think it's a step in a better direction to what we're doing at the moment, and of course antibiotics in some cases. So what I'm going to show you now is some work that Mona Ramati, who runs the clinic for us here, who's worked with Nathalie Ledet in Paris, presented at ESHRE some year ago. We've now been running for 3 years, and we've just submitted the data to the British Fertility Society for 3 years. But essentially, what we're able to find is that the majority of referred patients are identified to have a potentially treatable finding. Some of them we find nothing wrong, in which case don't change anything. The endometrium is probably fine. Ongoing pregnancy rates after testing and implementing a rational-based approach are encouraging. Again, we don't have the full control group because we haven't done a randomized controlled trial. But given this is a low prognosis group with an average of 7 embryo transfers before coming to us, getting this sort of result is certainly encouraging. And it changes the conversation. It brings a break in the dynamic between the doctor and the patient who's beginning to look increasingly angry at the doctor who hasn't failed so far. And the doctor says, well, I want to try something different. It resets the conversation, actually, in a very positive way in our experience. And as I said, it means a slightly more rational approach to what we're doing. So if we're doing this, I would say what we could be doing is this as our new strategy. Yes, a careful history is important. Look to see, has there been an element around response or fertilization, anything pointing to an embryo, an oocyte, or sperm factor. We need to look at that. But then rather than just saying, well, the embryo looks all fine, I'm going to squirt in some magic medicine, let's try and diagnose the endometrium as best we can. And then advise on the overall prognosis, which, as I'm going to show you in a minute, is better than we might think it is. Explain why implantation failure happens, because patients can often get very encouraged by the fact that there's nothing major wrong here, it's just nature kicking in. And base the clinical interventions, if you can, on as much rationale as possible than blind hope. So this is how we might be looking in the future. As more and more tests and markers of these new endometrial functions becoming available, analyzing mRNA and secretions or the nutritional component, looking at new receptivity markers. The microbiome is coming in. We don't have time to go into that to depth today, but there may be some value in assessing the microbiome, possibly even vaginally rather than endometrial, as some marker of the intrauterine environment. And something that our group are working on is trying to develop a way of assessing the incubator functions of the uterus to measure pH, oxygen, and temperature. And we're making some interesting progress in that regard. So I think in the future, we're going to have a much better, more shiny toolbox than the one we have now. So finally, I think the fact that ESHRE is looking at this is a good thing. We were initially, it was initially proposed that ESHRE should try and write a guideline on the management of recurrent implantation failure. And it was very quick to those of us in this field that that would be a very difficult thing to do. Some societies have done it. The Canadian Society's done one, the British Society's done one. But guidelines are normally based on published evidence. And the trouble with recurrent implantation failure is the way we've been investigating it has not been appropriate to develop that in a useful way. But there is a problem that you and I face every day, and there is probably a good practice that we could agree in that difficult situation we're in at the moment. So I have great pleasure working with some very eminent people in the field, and you will recognize some of these names. Our next meeting is next Friday, and hopefully we'll make some more progress to producing a document that I hopefully will be helpful in guiding you and your patients in the future. But my last slide is, I think, an important one, and it addresses the question that if your patient has recurrent implantation failure, should they be giving up hope, essentially? And the answer is emphatically no. We looked, and this is Yvonne Koch, one of my Dutch PhD students, working with Malene in Denmark, to look and follow up a large cohort of women who've been diagnosed with recurrent implantation failure, just to see what happened, how many of them got a baby in the end and over what period of time. And essentially what you can see from this is that within a few years of their diagnosis, half of them had had a baby. Now, obviously 100% had wanted it, but over that period of time, a lot of them got pregnant either with their own eggs, or with donor eggs, or indeed without even IVF. So diagnosing RIF is something we have to be careful about. For a large proportion of patients, it's just been bad luck. And if they keep going, they're going to get there. And I think that keep calm and carry on thing that we have in Britain is very appropriate for many of these patients. But we do need to understand that there will be a group, and this is the challenge, within that cohort where there is something diagnosable and treatable. So to conclude, ladies and gentlemen, and thank you for staying with me through this thus far. I hope I've been able to convince you of a few points. Firstly, that recurrent implantation failure is not something we should be treating as a medical diagnosis. It's nothing more than an experience. And what a patient or you will consider as being RIF will depend on so many other factors rather than the number of embryos that have been transferred, although that is helpful. Implantation failure is there for a reason. It's physiological. We need it as a species, because if we didn't, then either there'd be miscarriages having left, right, and center, or babies being born with severe problems. So it's there. And we take some risk when we try and overcome nature's barriers to implantation, as I've alluded to. The good news is that the overall prognosis after recurrent implantation failure is actually quite good. And in many of your patients, if you can just convince them to keep going, they'll probably get there without any additional magical treatments. Empirical therapies, we do need to be careful. If this is the one take-home message I would ask you to take, is please just stop trying a scratch, trying heparin, because the evidence is very conclusive now that that approach is possibly harming as many people as it is helping. So please, let's not do that. If we do it, let's be honest with the patients that we don't know whether it will do more harm than good. I'm not going to say to you that there'll be a patient who will demand it and put you in a difficult situation, but have that conversation. Therefore, the challenge is for us to diagnose the endometrium. And, you know, we're, what, 20 years behind the embryologists in this? They have fantastic ways of scrutinizing the embryo. Our focus on the embryo has stopped us from focusing on the endometrium, as has our attitude towards the endometrium as a passive receptive organ. It's much more complex than that. But we're learning that. The tests are going to come. And certainly for the next generation of doctors, I think there's going to be a very exciting endometrial toolbox available for our use in our patients in the future. And finally, once we can do that, then we can start building the evidence base we need, because we will diagnose the cause of implantation failure and then randomize to the intervention that we hypothesize will help that cause, or a placebo. And then we can start getting a good and strong evidence base to guide management. So thank you for the invitation, and thank you for listening to me this evening or this morning or this afternoon. It's important for me to acknowledge all the people whose work I've referred to in this talk, and there's a lot of them, and their work has been, in my view, very good, and they work very hard. So in Utrecht, the work I've shown you has been primarily from Lotte Weimar, Caroline Boomsma, and from Gijs Tecklenberg, who worked along with Lotte on the biosensor function. We did this in collaboration with Jan Brozens in Warwick. In Southampton, we've been looking at endometrial secretions and developing techniques of analyzing the intrauterine environment with a device to measure pH, oxygen, and temperature. And that work has been done together with Professor Ying Chong there. And I've listed a number of our other important key collaborators and PhD students. And then there's the implantation clinic in Zeeland University Hospital, which Milena ran for a few years. And here we have it, an implantation clinic in London with Mona Ramati and the Holbridge Centre nursing team, and indeed the doctors who refer their patients to the clinic. So I'd like to acknowledge all of them and thank you again for your kind invitation. Thank you.
Thank you so much, Professor Macklon. It was an excellent presentation, and I'm sure everyone who was listening would have benefited from the talk. So before we start some question answer session, I just wondered if Shailaja, you wanted to say something about Professor Macklon.
I think we must give time for the questions. I just think that you heard from the presentation today how the London Women's Clinic has benefited so much in so many ways, with Prof. Macklon being our group medical director. So it's just that it's brought an extra layer of not just clinical medicine, but evidence-based clinical medicine, where protocols are questioned, our clinical decisions are questioned. And I think this is just delighted that Prof. Macklon also has accepted this invitation, and we have 5,000 young students hopefully will benefit from the talk today. But I don't want to waste time. Let's go to the questions. Thank you, Prof, for taking the time today.
Thank you so much. So I was thinking that I will start off first, but please, those who are listening, please put forth your questions or anything that you would like to comment on, or Professor Macklon to feed you back on. So starting with a question for you, Professor Macklon. It's very interesting presentation, as I said, and brilliant. But most important is that recurrent implantation failure has been an enigma for many years. And there has always been this debate about evidence-based practice versus practice-based evidence that we should offer treatment or not. So what do you think? That should we just forget about RCTs? Because when we have RCTs, we may not have that many RCTs. And still, despite RCTs, people do consider going ahead with the same sort of investigations and all, which in their personal experience, they have found beneficial for their patients. So do you think we should go more by our personal experience and practice rather than strong evidence, or is there still a role for RCTs?
Well, thank you. It's actually a very interesting question. I mean, the obvious answer you'd expect to hear is that we need RCTs, and that's what we tend to come out with. If you actually look at when evidence-based medicine was first proposed and first defined back in the 80s, the contribution of study data was just part of it. It was basically the combination of evidence from well-designed studies with the clinical experience and knowledge of the doctor and the context and desires of the patient. So there's evidence in there, but it's not evidence required. It's not just only following the evidence. If we just did clinical practice by algorithm and said, look, there's no study to do this, then we would be in this catatonic state where we don't know what to do. Medicine, the real art of medicine, I think, is managing a clinical situation with insufficient information. That's what we all do every day. Remember your nights on labour ward. You just have to go, well, I've got to get this baby out somehow. You know, I can't go off and do a Cochrane review. And in the clinic, we're in that situation. But what we do want to do is make sure that any advice that we give to our patient is based on the evidence, the best evidence we have. And ideally, that would be based on randomized controlled trials carried out in patients who are exactly like your patient over the table. But let's be honest, in most cases, that's not the case. Your patient will have been too old to have taken part in those trials, perhaps. But that doesn't mean they don't have value. And I think I've been characterized in this debate recently as being anti-RCTs. I'm not at all. I mean, I've published several over the last few years. I've got a few going on at the moment. I think they're fantastic. But they're difficult, and they're not always available to us, and they're not perfect by any means, because they've all got limitations. So what I would basically come down to is I don't think we should be afraid of practicing clinical medicine to best of our ability when RCTs are not available. There may be situations where an RCT will draw a conclusion which is counter to your intuition in that clinical situation. Now, if you're experienced and you feel you've made a proper assessment of that patient and you're taking into account their context and desires, it could be financial, religious, all sorts of things, then your role as a doctor is to act in their best behalf. And that might sometimes means that somebody just looking at the result of an RCT would disagree with your decision, but that person hasn't made an assessment of the patient. So that's what I would say. What is important, though, if we adopt that view, is that we don't abuse it. I just think that gives us a free pass just to do whatever we want to in the patient's interest, because patients are hugely exploitable. So it actually puts more responsibility on us. So It's a rather long-winded answer to your question because it's quite a complex question, actually. I think if I was to summarize it, if you've got data from RCTs that are applicable to your patient situation, do use it to guide it. But if you don't, and you have reason to believe that a therapy would be, for whatever reason, beneficial, you don't need to be afraid of using it because someone has said in an RCT they didn't see it working. It comes down to judgment, and that's what medicine's all about.
Yeah, very well said. There is one question I would like to go on to, which has been asked by one of the delegates who have been listening. What is the role of MDM2 and IL-21 gene in RIF? What treatment is to be given for affected people?
It's an interesting question, and there could be, if I can anticipate it, 200 questions about people's favorite cytokine and gene and protein. There are lots of studies published where, and in my role with RBMO, I'm not the editor-in-chief, by the way, I'm just one of several editors, but in my role as editor, I see a lot of these studies coming past where people have looked to see, is this gene or this cytokine disrupted in recurrent implantation failure, often done in biopsies, and almost always they are. You know, it's, if you look at it, you know, they are. The difficulty is whether or not that is a causative issue or whether it's just a marker of something else. And therefore, one has to be cautious about jumping on the latest bandwagon. What it says to me is that, yes, there are potential markers there which could be useful in identifying therapies, but we should be cautious because, you know, if you go for IL-21, and there may be something in it, and start giving everyone the therapy, you know, for measuring, we need to understand first what its role is. Can I use an example? The microbiome, something that I'm very interested in, and many of you will be interested in. It's an exciting new area of medicine and certainly has applications for us. And there are studies now linking an abnormal microbiome, either in the vagina or the endometrium, to poor implantation. It's quite compelling evidence there. But there are key questions that need to be asked. One is it the microbiome the problem, or is the microbiome just a surrogate for something else? It's just a sign that who knows what, the endocrine situation isn't ideal, or there's a vitamin deficiency or something like that. So before we go rushing in and giving everyone antibiotics, we need to understand what is the marker telling us. And this applies to the two that you've mentioned thus far. So we need that research, and it's great that people are doing it. And I really like seeing people doing basic research. One of my messages to the research community is we've unbalanced it. We should be doing much more of that work and much less, in my view, resources into large empirical trials of, you know, everyone's using this, so let's see if it works, and we don't know how it might work, but let's do the trial. They're important, but until we really understand what's happening with IL-21 and all these things, we're going to still be having the same conversation in 10 years' time. So I suspect that's not the answer that your questioner wanted, but it's the one that I think is the appropriate one.
Yeah, back to basics is very important. I was thinking of another question. It is regarding endometrial receptivity and effect of age. So as a woman gets older, do you think endometrial receptivity would change, and would that result in implantation failure apart from the age-related effect on aneuploidy and the embryos? It's just specifically about the endometrial receptivity.
Very interesting question. Our traditional teaching is, but it has been that there's the ovaries at age and not the endometrium, and everyone points to egg donation, fantastic results.
Indeed.
They're not quite the same. You know, we've recently analysed at London Egg Bank our results, and women over 50 get great results with egg donation, but they're not quite as good. They're almost as good, not quite as good. Now, there may be a number of reasons for that, but I think it would seem intuitive that, you know, every part of our body suffers from aging, so why not the endometrium? It just seems to be far less prone to it. One interesting thing that I think we should consider, is a bit counterintuitive, is the role of the biosensor function. The reason why we think women get increased miscarriages as they get older is because the embryos are aneuploid. But there's possibly another mechanism I'd like to propose to people today, and I have no experimental evidence to back it up, so that's a study for someone to do. And that is that one of the reasons why we see more miscarriages in women above the age of 45 is that they're less good at detecting poor good quality embryos than when they were younger. They allow them to implant and turn into a miscarriage. Now, the evidence for that comes from the observation that if you look at the rate of aneuploidy in embryos and age, it's not linear. It actually is minimum at around about the age of 25, but it's actually slightly higher in 18, 19-year-olds.
Yeah,
So you'll see that data. It's a sort of a U-shaped curve. But 18, 19-year-olds don't get more miscarriages. I think what's happening is that their youth means that their biosensor is still working. And they're picking up these aneuploid embryos, and they're just not getting a positive pregnancy test. Whereas as we get older, the biosensor function is perhaps not working so much. So my thoughts would be that the impact of aging on the endometrium might be more profound, not on implantation, on preventing implantation, but on allowing inappropriate implantation. But that's just a theory at the moment, and I need someone to go and study it, please.
A very excellent talk, Professor Nick. You addressed almost all the issues so realistically. I have just one question out of curiosity in my mind. I think it was third or fourth slide of your presentation where you showed that the implantation rate in the natural pregnancy is around 30%, whereas in ART pregnancy is around 25%. So sometimes when I see all this, I feel, are we trying to optimize the implantation for the infertile couple more aggressively than what naturally occurs? Are we trying to surpass nature, and that is why we are persistently met with not convincing results of any particular way of managing our RIF so far? That's the question that comes to my mind.
Yes, thank you for the question. And yes, you're right. And I suppose the short answer, of course, with IVF, we're trying to beat nature, and but we're trying to, and we do that primarily by loading the numbers. We just get more eggs rather than one, and we can get more embryos and hopefully a good one, etc. And that works. You know, there's good evidence for that. But on the way, we may be harming the endometrium through ovarian stimulation. There's some evidence of doing that. And if you think about it, you know, with IVF on the whole, the odds are on our side, because rather than just one egg, we've got more eggs. We've got several embryos. We're selecting the embryos. Might even be doing PGTA, and yet we still struggle really to beat nature, as you've suggested. So it does require us just to take another view of this, and to recognise that the reason why we get so frustrated about this, and the particular problem, I think, is in pregnancy loss after a positive pregnancy test. It's terrible when that happens in IVF, because the stakes are so high and people have got so far, and we feel dreadful, and we analyze all our processes and double the progesterone dose. They may have some value, but this is just nature. You know, this is nature's quality control kicking in, as it does, and that's why we see the rate of pregnancy loss around about the same as we do in nature, and it probably does need to be there. Unless you take steps like making sure there's a euploid embryo, in which case we see miscarriage. Or possibly, if there is a woman with a deficient endometrium in some way that you diagnose, correcting that. But I think you're right. I think we have to understand that nature has put some well thought out barriers to implantation, evolved over millions of years, and they're there for a reason. And we should try and overcome them, I would almost say, at our peril, because all we're going to do is convert a negative pregnancy test to miscarriage in some of these women. That's not to say there's some women with a medically treatable problem, and that's what we're all here for as doctors. Perfect. But that's different from the overall population.
Yes.
Thank you.
Nick, I just wondered, we always, when we talk about recurrent implantation failure, we talk about causes that we can address in women. Do you think men, the other half, has any role in recurrent implantation failure or sperm factors, and should we be looking at that? Thank you.
Thank you. I'm not an andrologist, so let me sort of state that first, and there will be andrologists watching this who will have more knowledge on this field than me. But I think intuitively it is reasonable to expect that the male contribution to embryo quality is significant. We haven't yet, I think, found elegant ways of assessing that. We still struggle, don't we, when the embryo development is poor, to work out was it the egg with the sperm, but we'll get there. We've got some more tests coming in of sperm quality, such as DNA fragmentation, but we're not yet seeing, in my view, a link between our current ways of assessing sperm and recurrent implantation failure. I'm not saying it's not there, it's just that we probably haven't identified it. We do know that for instance, male smokers tend to lead to a higher miscarriage rate. And again, we can track the story there, 4,000 toxins, damage to the DNA, problem with the embryo, miscarriage. So there is some evidence from population studies that male factors will determine reproductive outcome, and we're getting more of those. I'm just not aware yet of a test that specifically predicts recurrent implantation failure, but I've got no doubt it will come in the end.
Right, thank you. I mean, I think I would ask one last question because I can see the time is running out. So Nick, now is the era of genomic medicine. We all talk about genomics and it's here to stay. Especially NHS England has done big role in genomic medicine. So what do you think about whole exome sequencing, the commercially available sequencing panels and genomics in recurrent implantation failure? And should we be offering that to our patients? Thank you.
Not now, because we don't understand it enough. I mean, one of the papers we published a few years ago with Yvonne when I was in Utrecht was we identified a transcriptomic profile that predicted recurrent implantation failure, a bit like an ERA test for RIF. There's a number of reasons why that didn't sort of enter commercial practice. So there are suggestions that, yes, like all things in life, there probably is a number of mutations, single mutations, which contribute to reproductive outcome, and we're still discovering what they are. The difficulty is that these things happen biologically upstream. And so if a gene doesn't get transcribed normally or gets over-transcribed, there are loads of steps that will determine whether or not the protein finally gets expressed and what type of glycosylation it has, etc. So drawing conclusions about clinical phenotype from genomics is very, very fraught with error. And there's been hundreds, of course. And that's one reason I think why genomic medicine has not given us the clinical advances perhaps we thought. We're still learning how to use it. That's different from things like extended carrier screening where we're looking for disease mutations. But I'm just talking in terms of helping implantation. I think it's some way off.
Yes. I mean, we currently got funding and we did a pilot feasibility study for recurrent miscarriage and genomics analysis. And as you rightly said, it is very difficult to conclude anything based on that because the picture is so varied when we look at genomic analysis. So I think it's a long way away still from clinical use or clinical practice in these fields, but very important to get your say on that. Thank you. Anyone else would like to ask any questions before we round up the panelists?
Shailaja, any questions?
Shailaja, you're muted.
Yeah, I think we have the implantation clinic, which Prof. Macklon guides, and we refer our patients routinely. We see the, of course, we don't give blind therapies anymore, and I think it reflects in a better clinical practice. So we have put some of these tests in place for some of our, frustrated patients. So it's been very helpful. But thank you, Nick. That's fine.
One question has just come up, and that is, it's asked, the questioner asks, the role of intralipids in RIF, is it better to give it 2 days before ET or on the day of ET? That is the question. He hasn't mentioned anything more. Is there a role for intralipids to be given before the embryo transfer to augment the implantation rate?
So if you look at the evidence base supporting the use of intralipid, it's very weak, but it suffers from the same issues as the other ones I've mentioned. I could have picked intralipid today, and I suppose it's one that's more frequently used. My view on intralipid is that it's a rather counterintuitive intervention. It's not without risk. It seems rather crude, but it does seem to be an immune modulator in the uterus. If you are going to use it, then I would say make some assessment of whether or not there's evidence of hyperimmune activity. Natalie Ledet, who provides our tests of immune, she's published a cohort study using intralipid. It's not a randomized controlled trial, sadly, but it's a cohort study, just saying, what happens when you use it. And she was reporting if you use it in women where there's evidence of hyperimmune activation, that it may be beneficial in that group. And I think that's probably where we are. I think if you have a patient who you think this is the issue, and you have access to intralipid and you can provide it safely, then I don't think you should be going to prison for using it, if I can use that terminology.
I think there are two more questions. Can we go ahead? Shaila, can you see those questions?
Yeah, I mean,
yeah, we see many. Yeah. You can go ahead.
So I can just, while Shailaja is unmuting herself. So Nick, I'm so sorry. I thought we were ending the meeting, but the last minute questions from the delegates are coming up.
Yes.
So do you recommend thrombophilia testing in RIF patients?
No. The evidence for it being a causative factor is very, very weak. When we use heparin, it's not to improve blood flow. It's as an immune modulator. The thrombophilia story has its origins in recurrent miscarriage. It's still tested there, but again, if you look at it there, the evidence for it being a contributor to failure is very low. And in fact, if you look at the most recent guidelines from ESHRE and recurrent miscarriage, they're not advising it that it be tested. We still do it, and doctors still do it because we might seek the reassurance when we've been told for years it is something that should be done. But I don't believe it. I think it's taken our attention away from where we should be looking. And so a short answer to is I don't think we need to do it. No.
Yeah.
Questions
and
now?
I think, same goes for abnormal placentation. In the sense, do you think patients with recurrent implantation failure, is there evidence to show they will have more problems with abnormal placentation? I think that's going in conjunction with the previous question of thrombophilia testing.
Yeah, I'm not aware of good data on that regard. I think my view on this for a while has been that while there is obviously a continuity in how they present clinically between implantation failure, recurrent miscarriage, preeclampsia, placentation, that the underlying pathologies are probably quite different. I haven't yet, but this is maybe a gap of my knowledge, I haven't yet seen a convincing story linking RIF to a higher risk of placental disorders.
Yeah.
One more question has popped up. Do we have time to take it?
I mean, I think the peripheral blood testing for NK cell, Nick has already addressed in his talk to say that there is no role for peripheral blood NK cells.
Absolutely. Yeah,
unless you need to add anything more to that.
Yeah, correct.
Okay, thank you so much, Nick.
Thank you so much.
Yeah. Presentation, and I'll pass it on to the organizers if they had to say the last word. Thank you.
Thank you very much.
Thank you so much. We are indeed very happy to see this fantastic webinar, and we have also seen the response is fantastic. As always, Meenakshi ma'am, you have added a lot with all this question and answer session. Thank you, Shailaja ma'am. Thank you, Rajan Vaidya sir. Finally, that you have been the main person to take this ahead. Thank you so much, sir.
Thank you. Thank you. Thank you, Professor Nick, Shailaja, and Meenakshi, and the MCure team. We had a fantastic webinar.
Thank you.
Thank you so much. Thank you. Bye.
Bye-bye.
Thank you, Doctor.
Bye-bye.